Hello my dear students. Today we shall be talking about an interesting and important chapter in cardiovascular system, that is coronary heart disease. Coronary heart disease, as it is said, is the most common form of heart disease and a single most important cause of premature death globally. The most common cause of myocardial ischemia, I hope by this point of time you must be knowing what is ischemia, that is reduced supply, blood supply to the muscles. If we are talking about cardiovascular system, yes, it is the reduced blood supply to the muscles of the heart, mainly myocardium. Most common cause of myocardial ischemia is atherosclerotic disease of epicardial coronary arteries. Narrowing of the large and medium-sized coronary artery due to intimal proliferation of smooth muscle cells with lipid deposition comprises of the entire syndrome of atherosclerosis. So, in atherosclerosis, there is narrowing of the blood vessel because of the subintimal proliferation of smooth muscle cells and finally deposition of fat, right? So, this leads to narrowing of the blood vessels. Further, atherosclerosis can be complicated by n number of complications. Thrombosis is one of them, which is most important. Now we'll be talking about clinical manifestations and pathology of various problems which is seen in coronary heart disease. Let's first talk about stable angina. I'll not be going into the detail because I feel that you must have learned what is angina and what are the various types of angina during your physiology and pharmacology classes also. So in stable angina, the pathology is there is ischemia due to fixed atheromatous stenosis of one or more coronary arteries, right? So there is a fixed atheromatous stenosis of one or more coronary artery leading to narrowing of the blood vessels and subsequent ischemia. In unstable angina, there is ischemia which is caused by obstruction of a coronary artery due to plaque rupture, ulceration or erosion with superimposed thrombosis. So this stable angina can get converted into unstable type when there is complication over the atherosclerosis in terms of there could be plaque rupture, plaque ulceration or erosion with superadded aggregates of platelets. Myocardial infarction, myocardial necrosis which is caused by acute occlusion of a coronary artery due to plaque rupture, erosion with superimposed thrombosis. Please understand, if there is myocardial infarction means there is necrosis of the cardiac muscle cell. Whereas in unstable angina or in stable angina, there is only ischemia. There is no proper muscle cell death which happens in myocardial infarction. Heart failure, which can be because of myocardial malfunction due to infarction or ischemia. It can also lead to arrhythmia. Arrhythmias can be because of altered conduction due to ischemia or infarction of the conducting system of the heart. Sudden death, which can be because of ventricular arrhythmias, asystole or massive myocardial infarction. Let's talk about stable angina. A few words about stable angina. Angina pectoris is the symptom complex which is caused by transient myocardial ischemia. Please take care of the word transient. Means there is transient myocardial ischemia. This may occur whenever there is an imbalance between myocardial oxygen supply and demand. Coronary atheroma is by far the most common cause of angina, because what happens whenever there is coronary atheroma, there is narrowing of the vessels, hence the supply is compromised. Normally during the periods of rest this is okay, but whenever a patient exerts, so at that time there is increased myocardial need, and at that time the artery is not able to supply that much of a blood. So there is an imbalance between oxygen supply and oxygen demand, and this leads to angina. The single most important feature of angina is its relation with exertion. I want you all to please concentrate on this important point. In angina, there is definite relation with exertion or stress. The history is by far the most important factor in making the diagnosis of stable angina. It is characterized by central chest pain, discomfort or breathlessness that is precipitated by exertion or other forms of stress, and it is promptly relieved by rest. Important part is patient gives you a typical history that whenever he exerts, he gets typical pain which is substernal, right? And this pain, whenever the patient takes rest, this pain goes on its own. So important feature of stable angina is pain which is promptly relieved by rest. Often described as pain but may present as pressure or squeezing sensation within the center of the chest. Some patients find that the discomfort comes when they start walking and that later it does not return despite greater effort, and this kind of angina is known as warm-up angina. And radiation of the pain is important, as I have already spoken in my initial presentations, that radiation of cardiac pain is important. This can go to the right arm, to the left arm, right. It can radiate to other places, like it can go to tooth. It can reach till occiput, but it never crosses the umbilicus. So there are n number of places where the cardiac pain can be referred to. So this reference or this referred pain part is important. Physical examination is often normal but should include a careful search for evidence of valve disease, particularly aortic, and important risk factors like hypertension, diabetes mellitus, history of cigarette smoking, as you must be knowing this thing, history of left ventricular dysfunctions which may lead to cardiomegaly, other manifestations of arterial disease as carotid bruit, unrelated conditions that may exacerbate angina like hyperdynamic circulatory states as anemia or thyrotoxicosis, pregnancy, beriberi. Importantly, please remember aortic stenosis, aortic regurgitation and hypertrophic cardiomyopathy should be excluded as they can cause angina even in absence of coronary artery disease. I think you can well understand. In aortic stenosis, there is gross hypertrophy of the left ventricle. So there is too much of muscle mass which needs supply, right? So even if the coronary arteries are not diseased, that coronary artery cannot really supply that much of the hypertrophy or that much of the additional muscle mass which has come out there. So in this condition, if despite the coronary artery being normal, patient can complain of anginal pain. So aortic stenosis, aortic regurgitation and hypertrophic cardiomyopathy should be excluded as they can cause angina even in the absence of coronary artery disease. Now, what are the various factors which influence the myocardial oxygen supply and demand? As I have already said, in stable angina, there is an imbalance between the supply and demand. Oxygen demand is being determined by cardiac work. And cardiac work, it is seen like heart rate. So, if the heart rate goes up, you can understand that the demand part would be more. Blood pressure, myocardial contractility, left ventricular hypertrophy and valve disease, as I have already stated, aortic stenosis. What are the factors which influence the oxygen supply or the coronary blood flow? That is duration of diastole. You know why? Yes, because the flow to the myocardium only occurs during the diastolic phase of the cardiac cycle. So duration of diastole will definitely have an influence over the oxygen supply. Coronary perfusion pressure, which is aortic diastolic minus the right atrial diastolic pressure. Coronary vasomotor tone. Oxygenation. Hemoglobin. If the hemoglobin is less, then definitely the oxygen supply part would be compromised. And oxygen saturation. Now we'll be talking about the investigations which we'll be doing in cases of angina. First of all is resting ECG. The most convincing ECG evidence of myocardial ischemia is the demonstration of reversible ST segment depression or elevation with or without T wave inversion. Please understand this important electrocardiographic finding that there is reversible ST segment depression or elevation with or without T wave inversion at the time when the patient is experiencing symptoms. You can also do an exercise ECG. An exercise tolerance test is usually performed using a standard treadmill while monitoring the patient's ECG, blood pressure and general condition. Planar or downsloping of ST segment of more than 1 millimeter is indicative of ischemia. Important point, planar or downsloping of ST segment of more than 1 millimeter is diagnostic of ischemia. Important from MCQ point of view. Then we can also go for stress scintigraphy, in which we do myocardial perfusion scanning. This may be helpful in the evaluation of patient, those who are unable to exercise or exercise test with low yield, as in patients with bundle branch block or women. Thallium-201 scintigraphy is commonly used to detect exercise-induced ischemia. A very commonly asked question in the MCQs. Thallium-201 scintigraphy is commonly used to detect exercise-induced ischemia. How come? Let's see. It entails obtaining scinti scans of the myocardium at rest and during stress after the administration of a radioactive isotope such as technetium-99 or thallium-201 in peripheral venous blood. Thallium is taken up by viable perfused myocardium. The part of the myocardium which is supplied by deceased myocardium and the areas of myocardial infarction will take less thallium than normal areas and will be visible as cold spots. A perfusion defect which is present during stress but not at rest provides evidence of reversible myocardial ischemia, whereas a persistent perfusion defect which is seen during both phases of the study is usually indicative of previous myocardial infarction. So this is a irreversible change. A radionuclide as technetium can be bound to RBCs by pyrophosphate. Here we will be imaging the necrotic myocardium. Now this radionuclide as technetium which can be bound to RBC by pyrophosphate, this then binds to calcium in irreversibly damaged myocardial cells, producing an image with increased uptake. So you get a hotspot on scan. Radionuclide typed RBC in the blood pool of the left ventricle can be used to produce a scintigraphic image of left ventricle. By gating the time that one measures the radioactivity which is coming out of this pool for systole and diastole, a ventriculogram can be produced. What are the other forms of stress testing? Stress echocardiography. This is an alternative to myocardial perfusion scanning and can achieve similar predictive accuracy. It uses transthoracic echocardiography to identify ischemic segments of myocardium in areas of infarction. The former characteristically exhibit reversible defects in contractility during exercise or pharmacological stress and later do not contract at rest or during stress. Coronary arteriography. This provides a detailed anatomical information about the extent and nature of coronary artery disease. Well, we have spoken a lot about the clinical features and the investigations. What next? The treatment. Anti-anginal drug treatment. I think you must have read this thing thoroughly in the lectures of pharmacology. Drugs which are used to help or relieve or prevent the symptoms of angina are: number 1, nitrates, beta blockers, calcium channel antagonists, potassium channel activators as nicorandil and ivabradine are used. Now, ivabradine is a drug which produces bradycardia by modulating the ionic channels in the sinus node. And an important point about ivabradine is it does not produce any cardiovascular manifestations or any cardiovascular adverse effects. So it can be safely given in cases of congestive cardiac failure also. Antiplatelet therapy, low dose, that is around 75 mg aspirin. It reduces the risk of adverse events such as myocardial infarction and should be prescribed for all patients with coronary artery disease indefinitely. Important, low dose. And why it is low dose, I am pretty sure you must have read this thing in pharmacology. Clopidogrel 75 mg daily is an equally effective antiplatelet agent that can be prescribed if aspirin causes troublesome side effects as dyspepsia or gastric distress. It is conventional to start therapy with a low dose aspirin, a statin, sublingual GTN and a beta blocker, and then add calcium channel antagonist or a long acting nitrate later if needed. The goal is the control of angina with minimum side effects and with the simplest possible drug regimen. There is little evidence that prescribing multiple anti-anginal drug is of benefit, and revascularization should be considered if an appropriate combination of 2 or more drugs fails to achieve an acceptable symptomatic response. Now we'll be talking about percutaneous coronary intervention versus medical therapy in stable angina. PCI is more effective than medical therapy in elevating angina pectoris and improving exercise tolerance, but does not reduce mortality. Now this point is important, which you should keep in mind. We can also go for coronary artery bypass grafting for stable angina. CABG is superior to medical treatment for at least 10 years after surgery in terms of survival. Greatest benefit occurs in those with a significant stenosis. Please understand, if there is a significant stenosis, then CABG is the treatment of choice. When there is a significant stenosis in left main coronary artery or those with 3 vessel disease and impaired ventricular function. So this is important from the MCQ point of view. If you are going for CABG, indications is significant stenosis in left main coronary artery or those with 3 vessel disease and impaired ventricular function. For patients with multi-vessel disease or diabetes, CABG appears to confer better survival rates at 4 to 5 years. Now, few words about angina with normal coronary arteries, important again from MCQ point of view. There are a number of MCQs which has been asked on this question. Angina, whereas the coronary arteries are normal. Let's see. Approximately 10% of the patient who report stable angina on effort will have angiographically normal coronary arteries. I will not call it a miracle, it happens. Let's see how. Many of these patients are women. You can get coronary artery spasm. This form of angina is sometimes known as variant angina, and it may be accompanied by spontaneous or transient ST elevation on ECG. And yes, such kind of angina is known as Prinzmetal angina, which is because of coronary artery spasm. And in ECG you can get transient ST elevation. Drug of choice for Prinzmetal angina is nitrates. For prevention, we can use calcium channel blocker. Again, it is asked very commonly in MCQs for variant angina or for Prinzmetal angina. Alright, the drug of choice happens to be nitrates, and for prevention, you can use calcium channel blockers. Syndrome X, the constellation of typical angina on effort, evidence of myocardial ischemia on stress testing, and angiographically normal coronary arteries is sometimes referred as Syndrome X. Now we shall be talking about acute coronary syndrome. Acute coronary syndrome is a term that encompasses both unstable angina and myocardial infarction. Unstable angina is characterized by new onset, means less than 2 months, severe and frequent or rapidly worsening angina, which is also known as crescendo angina, angina on minimal exertion or at rest in the absence of myocardial damage. When we are talking about unstable angina, please note still here there is no myocardial damage. Now, why I am putting forward this point, because in n number of MCQs they will give you an option that in unstable angina certain parameters would be elevated. Say, supposingly, if we talk about the enzymes which are released by the necrotic myocardium, please don't come in the trap. If it is stable or unstable angina, there is no myocardial damage. So this point is important, which you should keep in your mind. In contrast, myocardial infarction occurs when symptoms occurs at rest and there is evidence of myocardial necrosis as demonstrated by elevation in cardiac troponin or creatine kinase MB isoenzyme. So these enzymes will only be elevated when there is myocardial necrosis. Means this would be elevated mainly in cases when the patient is having or is suffering from myocardial infarction. So please try to understand angina, that is stable and unstable. Here there will be no elevation of these enzymes. Whereas if the patient is suffering from MI, yes, there could be chances of elevation in cardiac troponin or creatine kinase MB isoenzyme. An acute coronary syndrome may present as a new phenomena or against a background of chronic stable angina. The culprit lesion is usually a complex ulcerated or fissured atheromatous plaque with adherent platelet-rich thrombus and superimposed local coronary artery spasm. This is a dynamic process whereby the degree of obstruction may increase, leading to complete vessel occlusion or regress due to the effects of platelet disaggregation and endogenous fibrinolysis. So this might regress or it can further go up and leading to severe MI. In case of acute myocardial infarction, an occlusive thrombus is present at the site of rupture or erosion of an atheromatous plaque. So there is an occlusive thrombus which is there, which is superimposed onto the atheromatous plaque, and because of this plaque and superimposed thrombosis, the lumen of the artery is narrowed to a great extent, to an extent that the artery will not be able to supply to the distal myocardium, and this will lead to myocardial infarction, means death of myocardial cells. The thrombus may undergo spontaneous lysis over the course of the next few days, although by this time irreversible myocardial damage has already occurred. The process of infarction progresses over several hours, and most patients presents when it is still possible to salvage some portion of the myocardium and to improve clinical outcome. The most common site of myocardial infarction is the anterior wall of the left ventricle. N number of MCQs has been phrased on this important fact that the most common site of myocardial infarction is the anterior wall of the left ventricle. The commonly involved arteries are left anterior descending and right coronary arteries. So these are the arteries which are commonly involved. Can you see I have changed the color of left circumflex coronary artery because left circumflex coronary artery is underrepresented in an ECG. So because left circumflex coronary artery is supplying the posterolateral wall which is very less represented in an ECG. So at times the ECG may be normal and the patient may be having occlusion of left circumflex coronary artery. So there is something which you should keep in mind, and marginal arteries are uncommonly involved. So again this fact is important from MCQ point of view. They will give you what are the arteries which are commonly involved, 1, 2, 3, 4, and if you find marginal arteries, yes, you know these are the arteries which are very uncommonly or rarely involved. What are the symptoms of myocardial infarction? There is prolonged cardiac pain. In stable angina, as I have already said, there is pain during exertion, but once the patient takes rest, pain subsides. Whereas in myocardial infarction, there is prolonged cardiac chest pain which can go on for say around 15 to 20 to 30 minutes also. It is seen at the substernal region, and patient very commonly says like this, he always complains with a clenched fist, right? He will never say like the pain is out here or it's out here. It is very commonly seen feature is the patient will say it like this, the substernal discomfort. It can radiate to throat, arms, and my dear students, please remember this very important point to epigastrium also. Now why I am saying epigastrium, because it is very important that say a 50 to 60 year old patient comes to you with complaints of pain in the epigastrium, and he gives you an history that I have been taking omeprazole for a number of days because of my acidity, and then there would be an MCQ which says what could be the probable diagnosis. He might only be having symptoms of breathlessness, whereas the entire MCQ will be framed or will be positioned in such a way that your entire attention will be focused towards the epigastrium and symptoms of gastritis. But please understand, the pain of myocardial infarction can be referred to epigastrium also, and if a 40-year-old patient complaining of breathlessness and epigastric pain, definitely you have to go for an ECG, and you should not just think that this could be a pain of simple gastritis. Again, this fact is important from MCQ point of view. So pain can be there in the epigastrium, or it might radiate to back also. Painless infarcts may be seen in diabetes mellitus, women's, and in persons of old age. So at times in diabetes mellitus, patient will not be having pain. There is anxiety and fear of impending death, nausea and vomiting. There could be breathlessness, as I have already said. So a classical case, 50 to 60 year old patient, breathlessness and pain here and there, right? The MCQ might be framed to confuse you, but you have to understand that if the MCQ is fitting in a particular age of a patient, and they are giving you a hint of breathlessness, you have to tap it, and then accordingly you have to identify, and you should not come into that particular trap. So breathlessness, collapse, or chances of syncope. In physical signs, there could be signs of sympathetic activation like pallor, sweating, tachycardia. There could be signs of vagal activation as vomiting or bradycardia. There might be signs of impaired myocardial function as hypotension, oliguria, cold peripheries, raised jugular venous pressure, and yes, a third heart sound. There could be signs of tissue damage as fever, and you might also get some signs of complications as patient might develop mitral regurgitation or pericarditis. Mitral regurgitation can develop because of infarction of a papillary muscle or chordae tendineus. So patient might get this complication also. What are the various lab tests which we'll be doing in this particular cases? There are certain non-specific indexes of tissue necrosis and inflammation as leukocytosis, raised ESR. You have to take an ECG, you have to see the serum enzyme changes and ultimately cardiac imaging. Now let's talk few words about the investigations. Mainly we'll be talking about electrocardiography or an ECG. The ECG is central to confirming the diagnosis of myocardial infarction. And please remember, but may be difficult if there is bundle branch block or some previous MI or posterolateral wall infarction. As I have already narrated earlier, if there is posterolateral wall infarction, this area is underrepresented in ECG and so you might miss it also. The initial ECG may be normal or non-diagnostic in 1/3 of the cases. So if the initial ECG is inconclusive, what has to be done? Yes, you have to repeat the ECGs. Repeated ECGs are important, especially where the diagnosis is uncertain or the patient has got recurrent or persistent symptoms. Definitely you have to go for repeat ECG. The earliest ECG change is usually an ST segment deviation. Please remember this very important point. The earliest change which you will get in an ECG in case of myocardial infarction is an ST segment deviation. Now why I am saying deviation? Because this could be elevation or depression. Let's see in which conditions you see depression and in which condition you see elevation. With proximal occlusion of a major coronary artery, ST segment elevation is seen initially, with later diminution in the size of R wave and in transmural or full thickness infarction. Later on, you can get a Q wave. So if it's a transmural infarction, then you will be getting ST elevation. This is also known as STEMI, that is STEMI, ST elevation myocardial infarction. So STEMI is seen when there is transmural or full thickness infarction. Subsequently, the T wave becomes inverted because of the changes in ventricular repolarization, and pathological Q wave is seen in a fully evolved case, right? So as the case is evolving, later on you can get T wave inverted and a pathological Q wave. This change even persists after the ST segment has returned to the normal. So if you are talking about a fully evolved case, you will be getting two things: T wave inverted and a pathological Q wave. In non-ST segment elevation, that is known as non-STEMI, acute coronary syndrome, there is a partial occlusion of a major vessel, whereas in STEMI there is complete occlusion. In this case, in non-ST segment elevation, there is partial occlusion of a major vessel or complete occlusion of a minor vessel, causing unstable angina or partial thickness or subendocardial myocardial infarction. So I hope by this time you have understood what is transmural or full thickness or STEMI or subendocardial or non-STEMI. This is usually associated with ST segment depression and T wave changes. So transmural ST segment elevation in ECG, subendocardial ST segment depression in ECG. Pathological Q wave and normal ST segment and T wave is seen in old infarction. The ECG changes that are best seen in the leads that face the ischemic area or the infarcted area. When there has been an anteroseptal infarction, abnormalities are found in one or more leads from V1 to V4, while anterolateral infarction produces changes from V4 to V6 in AVL and in lead 1. Inferior infarction is best shown in leads 2, 3 and AVF. Infarction of the posterior wall of the left ventricle does not cause ST elevation or Q wave in the standard leads, but can be diagnosed by the presence of reciprocal changes, that is ST depression and tall R wave in leads V1 to V4. Important: ischemia in the area of distribution of left circumflex artery is difficult to detect on a 12-lead standard ECG. Again, a very commonly asked question in MCQ, because this area is electrographically silent. The most sensitive lead in detecting intraoperative ischemia is lead V5, and it has the greatest sensitivity. If two leads can be displayed, it should be V4 and V5 because it gives rise to around 90% sensitivity. In stable and unstable angina, there is no detectable rise in cardiac markers or enzymes. Please remember this point, as I have already briefed you initially, that in case of stable and unstable angina, there is only ischemia. There is no actual myocardial cell death. So there will be no rise in the cardiac markers or enzymes, and the initial diagnosis is made from the clinical history and ECG only. MI causes a rise in the plasma concentration of enzymes and proteins that are normally concentrated within the cardiac cells. These biochemical markers are creatine phosphokinase, a more sensitive and cardiospecific isoform of this enzyme, that is creatine phosphokinase MB, and cardiospecific proteins, those are troponins T and troponin I. Admissions and serial, that is usually daily estimations of these enzymes are helpful because it is the change in plasma concentration of these markers that confirms the diagnosis of myocardial infarction. So you have to admit the patient and then you have to do serial estimation to see that whether these enzymes are increasing or not. Creatine phosphokinase starts to rise at 4 to 6 hours, peaks at about 12 hours and falls to normal within 48 to 72 hours. LDH rises later, that is after 24 to 48 hours, and remain elevated for 7 to 14 days. Now please understand, creatine phosphokinase, it rises at around 4 to 6 hours, peaks at around 12 hours and falls to normal within 48 to 72 hours. So if the patient comes to you after 72 hours, there are very less chances that you will be getting elevated creatine phosphokinase. Again, such facts can be asked to you in form of an MCQ. Creatine phosphokinase is also present in skeletal muscle, and a modest rise in CK but not CKMB may be due to an intramuscular injection or vigorous physical exercise. Defibrillation causes significant release of CK but not CKMB or troponins. Important, please note, the most sensitive marker of myocardial cell damage are the cardiac troponins, that is cardiac troponin T and I, which are released within 4 to 6 hours and remain elevated up to 2 weeks. Now these are the most sensitive markers to confirm the diagnosis of acute myocardial infarction. These are not the investigation of choice for reinfarction after 4 days. I was going through MCQs. Now they have mentioned what is the investigation of choice if the patient suffers a reinfarction after say 4 days. Definitely cardiac troponin T and I will not be the choice because they remain elevated till the period of 2 weeks. So you will not come to know that there is a fresh infarct. So the answer would be CKMB. Isoenzyme will give you an idea about reinfarction if it occurs after 4 days and not cardiac troponin T and I. Other tests, a leukocytosis is usual, reaching a peak on the first day. The ESR and C-reactive proteins are also elevated. Chest X-ray may demonstrate pulmonary edema that is not evident on clinical examination. The heart size is often normal, but there may be cardiomegaly due to pre-existing myocardial damage. Echocardiography, important. This is useful for assessing left and right ventricular functions and for detecting important complications such as mural thrombus, cardiac rupture, ventricular septal defect, mitral regurgitation and pericardial effusion. So if these complications have developed, the choice of investigation should be echocardiography. What is the immediate management which is done within the first 12 hours? Patient should be admitted urgently to hospital because there is a significant risk of death or recurrent myocardial ischemia during the early unstable phase, and the appropriate medical therapy can reduce the incidence of these by at least 60%. So time factor is very important. Ventricular fibrillation is the most common cause of arrhythmic death in myocardial infarction before the patient reaches hospital. Alright, so ventricular fibrillation is the most common cause of outpatient death before the patient reaches hospital. Most death occurs in 24 hours and half of them occurs within first hour. And pump failure is the primary cause of death in hospital death. So early cause of mortality could be ventricular fibrillation, and if the patient has reached an hospital, means after some time, the cause of mortality or cause of death could be pump failure. Now as far as the treatment is concerned, first of all, the patient is having very severe pain. It has been mentioned in various books that this could be perhaps one of the most worst kind of pain which patient has ever experienced. So you have to take care of the pain, and accordingly an adequate anesthesia has to be given. Adequate anesthesia is essential not only to relieve distress but also to lower adrenergic drive and thereby reduce vascular resistance, blood pressure, infarct size and susceptibility to ventricular arrhythmias. So you can understand how important it is because ventricular arrhythmias can also lead to death. Intravenous opiates, initially morphine sulfate 5 to 10 milligram or diamorphine 2.5 to 5 milligrams should be given, and antiemetics like metoclopramide 10 milligrams should be given. Then we come to the antithrombotic therapy. We have to give antiplatelet therapy to smokers. In patients with acute coronary syndrome, oral administration of 75 to 300 milligram aspirin daily improves survival with a 25% relative risk reduction in mortality. This point is important. The first tablet 300 milligrams should be given orally within the first 12 hours, and therapy should be continued indefinitely if there are no side effects like dyspepsia. In combination with aspirin, the early within 12 hours use of clopidogrel 600 milligrams followed by 150 milligram daily for 1 week and 75 milligrams daily thereafter confers a further reduction in ischemic events. Anticoagulants. Anticoagulation reduces the risk of thromboembolic complications and prevent reinfarction in absence of reperfusion therapy or after successful thrombolysis. Anticoagulation can be achieved using unfractioned heparin, fractioned or low molecular weight heparin, or a pentasaccharide. Anti-anginal therapy. Sublingual glyceryl trinitrate is a valuable first aid measure in unstable angina or threatened infarction, and intravenous nitrates are useful for treatment of left ventricular failure and relief of recurrent or persistent ischemic chest pain. To continue with the immediate management, we have to give intravenous beta blockers, mainly cardioselective beta blockers like atenolol, 5 to 10 milligrams, which relieves pain, reduces arrhythmias, which is very important role of beta blockers, and improves short-term mortality in patients who presents within 12 hours of the onset of the symptoms. However, there are definite contraindications of beta blockers, as you must be knowing out of your knowledge of pharmacology. The contraindications of beta blockers: if there is heart failure or if there is hypotension, mean systolic BP less than 105 millimeter of mercury, or bradycardia, heart rate less than 65 beats per minute. A dihydropyridine calcium channel antagonist, example nifedipine or amlodipine, can be added to beta blocker if there is persistent chest discomfort, but may cause an unwanted tachycardia if used alone. So if you are using nifedipine, it can cause tachycardia, so it's given with beta blockers. Because of their rate limiting action, verapamil and diltiazem are the calcium channel antagonists of choice if a beta blocker is contraindicated. Now we'll be talking about an important therapy, that is reperfusion therapy. We know the problem was the perfusion was getting compromised because of some obstruction. This obstruction was because of atherosclerosis and its superadded complications like thrombosis, right? So there was problem in the perfusion. The aim is to reinstate perfusion. So we'll be talking about reperfusion therapy. In non-ST segment elevation acute coronary syndrome, please note, immediate emergency reperfusion therapy has no demonstrable benefit in patients with non-ST segment elevation MI, and so thrombolytic therapy may be harmful. So if the patient is suffering from non-STEMI, right, immediate reperfusion therapy is not beneficial and hence it is to be avoided. Selected medium to high risk patients do benefit from in-hospital coronary angiography and coronary revascularization, but this does not need to take place in the first 12 hours. So important as in non-STEMI, we should avoid reperfusion therapy initially. In ST segment elevation acute coronary syndrome, immediate reperfusion therapy restores coronary artery patency, preserves left ventricular functions, and improves survival. Therefore, successful therapy is associated with pain relief, resolution of acute ST segment elevation, and sometimes the transient arrhythmias also. Hence, this is the treatment of choice for ST segment elevation myocardial infarction, early reperfusion therapy. Outcomes are best when it is used in combination with glycoprotein 2B/3A receptor antagonist and intracoronary stent implantation. In comparison to thrombolytic therapy, it is associated with a greater reduction in risk of death, recurrent MI or stroke. Very important point. The universal use of primary PCI, that is primary percutaneous coronary intervention, has been limited by availability of the necessary resources to provide this highly specialized emergency service. When primary PCI cannot be achieved within 2 hours of diagnosis, thrombolytic therapy should be instituted or should be given. The benefit is greatest in those patients who receive treatment within first few hours. Here one point is important, minutes means muscle, right? So it is important to start it as soon as possible. Alteplase, which is an human tissue plasminogen activator or TPA, is genetically engineered drug which is preferred in this condition. Its use is associated with better survival rates than other thrombolytic agents such as streptokinase, but do carry a slightly higher risk of intracerebral bleed. Analogues of TPA such as tenecteplase or reteplase have a longer plasma half-life than alteplase and can be given as intravenous bolus. Tenecteplase is as effective as alteplase in reducing death and myocardial infarction while conferring similar intracerebral bleeding risks. However, other major bleeding and transfusion risks are lower, and practical advantages of bolus administration may provide opportunities for prompt treatment in an emergency department. The major hazards of thrombolytic therapy is bleeding. Cerebral hemorrhages causes 4 extra strokes per 1000 patients treated accordingly. The treatment should be withheld if there is a significant risk of severe or serious bleeding. Prompt thrombolytic treatment within first 12 hours and particularly within 6 hours of the onset of symptoms reduces mortality in patients with acute MI and ECG changes of ST elevation or new bundle branch block. Intracranial hemorrhage is more common in people given thrombolysis with 1 additional stroke for every 250 people treated. Now, what are the relative contraindications to thrombolytic therapy? These are the potential candidates for primary angioplasty. That is an active internal bleed, previous subarachnoid or intracerebral hemorrhage. If the patient is having some intracerebral hemorrhage or if the patient is having some previous subarachnoid bleed, thrombolysis is contraindicated. It is also contraindicated in malignant intracranial neoplasm. Again, a question asked in MCQs very commonly. Malignant intracranial neoplasm, thrombolysis therapy is or thrombolytic therapy is contraindicated. Uncontrolled hypertension, recent surgery within 1 month, recent trauma including traumatic resuscitation, high probability of active peptic ulcer and pregnancy are all contraindications to, or they are all relative contraindications to thrombolytic therapy. Now, what are the complications of acute coronary syndrome? As I have already said, before a patient might reach a hospital, he might die en route, and the most common cause is ventricular fibrillations or arrhythmias. So, patient can develop arrhythmias like atrial fibrillation, ventricular fibrillations and bradycardia. There could be acute circulatory failure or pump failure is the most important cause of death once the patient reaches hospital. So, this is the most important cause of in-hospital death as a complication of myocardial infarction. There could be pericarditis also. Few MCQs have been framed on this important syndrome which is also known as Dressler's syndrome. What is that? The post-myocardial infarction syndrome, which is also known as Dressler's syndrome, is characterized by persistent fever, pericarditis and pleurisy, and is probably due to autoimmunity. The symptoms tend to occur within a few weeks or even months after infarct. Now, this point is important. You should understand the symptoms of Dressler's syndrome. They can come weeks or months after myocardial infarction, after the infarct, and often subside after a few days. Prolonged or severe symptoms may require treatment with high-dose aspirin, NSAIDs, or even corticosteroid. Now, what are the various complications? To continue, the mechanical complications, there could be a rupture of papillary muscle, which can cause acute pulmonary edema and shock due to sudden onset of severe mitral regurgitation, which is the common valvular lesion seen in this condition, which presents with a pansystolic murmur and a third heart sound. There could be a rupture of interventricular septum or rupture of the ventricle. There could be systemic embolism. It could also lead to impaired ventricular function, remodeling and ventricular aneurysm. Finally, we will be talking about the late management of myocardial infarction, risk stratification and further investigations. We have to advise the patient for lifestyle modification as cessation of smoking, regular exercise, diet, weight control, and should take care of its blood lipids, rehabilitations and devices like implantable cardiac defibrillators can be used in high risk patients. Secondary preventions in drug therapy, we have antiplatelet therapy like aspirin or clopidogrel can be used, beta blockers can be used, ACE inhibitors or angiotensin receptor blockers, definitely they reduce the chances of stroke also in such patients. You have to give statin to keep blood lipids or cholesterol under control. Additional therapy for control of diabetes and hypertension, and finally an aldosterone receptor antagonist.